introduction. It's a pleasure to be here. I too would like to thank Elder Point for his opening remarks. And I'd like to thank the First Nations Health Council and the directors for convening this important gathering. You've got such a rich and exciting agenda over the next couple of days. There's lots of opportunity for learning, and so many important subjects will be touched upon that have to do and touch so closely in terms of the well-being of First Nations children, youth, and families in British Columbia. So it's an agenda with a lot of promise, and I really lift my hands up to the organizers for presenting a strong lens and focus on children and families, and particularly on children and youth. And I also would like to express my really sincere thanks to the Council, the First Nations Health Council, for building bridges with those who are working in child welfare and child serving organizations. We just finished a pretty significant forum on reconciliation in child welfare that was hosted by the delegated Aboriginal agencies, the Ministry for Children and Family Development, and my office, which was really focused on changing the pathway for First Nations children in care. And as you know, in British Columbia, there are approximately 5,500 Aboriginal children who are either in temporary or permanent care, living out of the parental home. Many of those children are not adequately connected to family, to community, to culture, to language, and some are, increasingly some are, but there's a huge challenge to have what we call permanency, meaning a permanent cultural connection, permanent family legal connection, so the guardianship is clear for those children, ideally with a family member, because children have a right to be raised within their family and within their extended family when, for whatever reason, their birth parents are not able to care for them. And also to have stable permanency, meaning they are not constantly moving. And you will know from some of the work that I've done in my office that we've had a very strong focus on how Aboriginal children and youth in British Columbia are served. And you will know from the variety of reports that have been put out by my office, and I've worked with some of you around advocacy for children and families. We've had about 14,000 advocacy cases since we actually opened our advocacy in 2007. Many of those are Aboriginal children and youth. You will know that we have very strong views at the Representative's Office that the current system is not adequately serving and supporting Aboriginal children, youth, and their families. The system has a long way to go, particularly in the 6 key areas that the Ministry for Children and Families serves, with their approximately $1.3 billion budget, to have, first of all, positive helping relationships with First Nations families, positive relationships with communities, and clearer accountability for how children and families are served and supported. And what we've done in the work in our office, apart from advocacy, is to really, in some of these reports and some of this advocacy in the public, is to talk about what I call the pathway for a child that maybe comes into care, a child that may be maltreated, abused, or neglected, because children don't usually come into care just through random selection. They come into care because often some very serious things are occurring in their families. As many in this room know, sort of the top 3 underlying reasons have to largely do with domestic and family violence, violence against women, addictions, particularly unmet needs around addictions, and unmet needs around mental health. So some of the work of my office has really looked at the path. What happens to the child, and what has happened in the lives of specific children? And how can we change the path that many of those children and youth have walked on, that they haven't been appropriately supported? And as you know, some of that work has found very significant unmet health needs. Not having appropriate identification of special needs, meaning developmental special needs that should be identified early, that sometimes we don't see till much, much later in their school, that they had very serious challenges that should have been supported through effective, for instance, speech pathology, occupational therapy, positive education and support to their families and their communities, in their family, community, and in their school. Also having significant issues around the service model at times, which is really, is struggles between an interventionist model of removing children and a support model around working with community, family, and understanding how to do that work. So for sure, with the Ministry for Children and Families and my oversight role, I've certainly noticed and commented repeatedly on the challenges that they've had, despite very clear legislation in British Columbia and very clear policy to work with communities and families effectively. The reconciliation forum that we held recently that the council participated in really focused on the issue of so-called adoption. And we all have had very particular views about adoption because adoption was a device that was very interventionist in the lives of Aboriginal families and First Nations families, and saw certainly in the 50s and 60s removals of children from their family and tribal connections, and has caused a lot of harm and grief to people because it wasn't done appropriately. At the same time, we see in British Columbia, of these 5,000 plus children in care, they tend to drift through foster care with multiple placements. An Aboriginal child in care in British Columbia is many multiple times, 5 to 8 times more likely to drift through care and spend their entire childhood in foster care, which generally means multiple placements, moving into group homes, frequently moving into life in the street, as opposed to having the benefits of a stable, connected family. The approach to permanency and reconciliation and adoption is really about building and re-recognizing some traditional and ongoing practices around permanency, like customary adoption. Customary adoption is recognized in British Columbia. It's in Section 46 of the Adoption Act. But in my time as representative, I've only seen a single recognized customary adoption. I've seen a lot of informal arrangements where families raise extended family members, but I haven't seen a really deliberate, focused, engaged program to connect children to family and support those families. That's why we had a very deep discussion about what is reconciliation for First Nations children around what we call permanency or adoption. So when we think about those 5,000 plus Aboriginal children that are in care today, what is the likelihood that those 5,000 children will be connected strongly to their community, to their extended family, and placed safely back with their extended family? Well, I know, and I'm sure many of you in this room who maybe are raising children or playing a role in that regard, I know it's possible for every single one to be placed if we want to do it. And if you want to do the work differently and effectively, it can be done. So one of the goals that we certainly have is to bring this forward and talk about the experiences of young people who don't find that connection and what happens to them and how desperately they want that. And to promote, especially within the Ministry for Children and Families, and delegated Aboriginal agencies, First Nations health directors, all people can come together so that maybe we could take more of a whole child approach and we could see things like customary adoption be recognized. What is one of the main obstacles? You can say, well, what have you found, Mary Ellen, when you've looked at this issue? Why are there 5,000 children there? There are many healthy, strong, vibrant families in every community that would open their doors and have tried to open their doors frequently to the ministry to say, we want to place a child. What are the obstacles that I've seen? Well, it's very simple. An Aboriginal child off reserve, the family can receive support through post-adoption assistance. On reserve, post-adoption assistance is not available. It's a very simple explanation. So as a result, structurally and systematically, we don't do enough family finding. We had a program, it may not have been perfect, but it was a program called Guardianship Financial Assistance. supported about 6,000 to 7,000 children on reserve. It was eliminated. We had a program for children in the home of the relative, off reserve. Some kids are still grandfathered in it. It was eliminated and replaced with something called extended family program, yet less than half children are coming into that every month than were before. So I know for a fact that there have been real disincentives around actually supporting First Nations families to be caring for their extended family members. And the obstacles, particularly in my work, that I've seen where grandparents, aunts, and uncles have not been able to get even the minimal support that they require to be able to provide that kind of permanency, safety, and connection for those kids. I'm not saying some are not working as restricted foster parents, for instance, today, or aren't under a kith and kin agreement, or a few other arrangements, formal and informal, but they're few and far between for what they could be. And the reason why I say this is just to say when we take a lens around the determinants of health and the right to be safe, the right to grow up and be connected, something like setting clear outcomes with a very strong First Nations lens, taking very significant attention to culture and the need to stay focused on the child's need, it is quite possible, I feel, in British Columbia to change those outcomes. These are not unchangeable and unmovable. And certainly, as many of you know, working in health, we've seen a lot of change. I know that it's early in the tripartite agreement, it's early in the transfer, but I certainly see a very positive approach to wellness and health as a result of the partnerships that have developed through the transfer of authority and the conversation on health, and I think that's positive. In child welfare and the child serving system, it's been a more complicated process. It's been hard to have clarity. It's been hard to have everyone together to work on it. But I would really urge you to think, of course, in your everyday roles that you have as directors and staff working in First Nations Health, to think about the multiple ways to do what you can to support that cohort of very vulnerable children who are likely to be living outside the parental home and outside the family, and to think about how we can improve their health and to be an advocate for good service. And where there is not good service or history, to change that. So I would really like to see in every region of the health regions, and in every region for the Ministry for Children and Families, and in every school district, that we actually took real cases of real children, like I report in my reports, and show the service pathway that they have. And, you know, the issue about First Nations leadership and health directors needing to know where are these children, these 5,000 plus children. I'm urging very strongly the Ministry for Children and Family Development, and I believe they are going to respond to this, and I'm really supporting them to do this, to specifically report to every First Nations in BC, every First Nation. Ideally that would be shared, of course, through delegated agencies, more broadly through health agencies, the actual identity of the children who are in care, because many of these children are in an urban context, they've lost contact, community probably doesn't know where they are so that they can play the important role that they want to play. So I want the ministry to be accountable to give that opportunity, not just to say, here, your First Nation, there are 27 children. Here's where they're living. 5 are in Surrey, 5 are in Prince Rupert, 5 are in Nanaimo. You know, not just that, but actually to say this is an opportunity to plan differently together for their lives so that these kids will be successful. And one of the things I've urged the ministry to do as a bridging, if you like, is to amend their child welfare legislation so there will be an annual review. Every year there will be a review of the status of those children to see how much progress is being made on permanency, meaning also cultural permanency, and reconnecting those children into their family and community of origin. And that process would mean every year there's a strong external accountable process where the ministry has to come forward and say, this is what we've done in the last year, And that gives an opportunity to say, okay, well, we want to work with you, and actually to start partnering more effectively around the lives of those children. I will, in just a few short weeks, release a report that's probably the hardest report ever done by my office, which is about an Aboriginal girl who came from the interior with her mom, her mom, an active addict struggling with very serious intergenerational trauma, and mom followed the familiar pathway that we know that many Aboriginal women follow to the downtown east side. This little girl was raised for 2.5 years in the downtown east side. She lived in 50 SROs, despite there being policies that there's not supposed to be any children in SROs, youth shelters, transition homes, sometimes sleeping on the street. Her mother overdosed numerous times. This little girl aged out at 19 and herself died of a drug overdose in the downtown east side. We will tell the story about this girl. Her name's Paige. I hope you'll have a chance to read the story from a health lens and see that for women, the pathways in British Columbia are not always a healthy pathway. There were multiple opportunities to improve the life of this young girl. Her mom, she was born to her mom when mom was 16. Mom was in a very abusive, violent relationship with another individual who was in heavy addictions. The little girl lived for a while with her grandmother. Her grandmother also struggled with serious addictions. A person lived in the grandmother's home, the grandmother's boyfriend that perhaps molested this little girl when she was there. And this little girl at 19 had a short life of incredible disruption and trauma. And in fact, her great-grandmother died of a drug overdose. Her mother died of a drug overdose just shortly after she died of a drug overdose in British Columbia. 3 generations of women. So we all are familiar with these issues of addictions. These are not unknown to us in our families and our communities. We don't talk about these stories because we're trying to hurt people, but we talk about them because there is a very significant indifference in our system, that somehow that is the normal pathway for a cohort of girls and women, that they will end up like this. I have yet to meet a single girl or a woman that comes out of the downtown east side a stronger, better, more vibrant person. It's extremely rare, yet that's the pathway. And ironically, this little girl, when she came to the downtown east side, 15, turning 16, she was actually excited to come there because she thought maybe she'd be able to go to school. She tried to enroll in school, but of course, it's hard to enroll in school when all of your life's possessions are essentially in a garbage bag and you move from place to place, or sometimes your mom's in an SRO and you're left standing on the street in Vancouver and you're homeless. And repeatedly in this girl's experience, there were people in the healthcare system, because 17 times she went to a hospital in the Lower Mainland with a drug overdose or an alcohol severe intoxication, and she'd be released back to the very same environment almost every single time, and frequently released back without even the hospital staff notifying the Ministry for Children and Families that this was a child in desperate need. Police encountered her at least 40 times on 40 files. Sometimes they reported, sometimes they didn't. And you will see that when you look at the pathway of just one child, again and again and again, it's an attitude of indifference, just recording the downward spiral of children who have been abused, maltreated, and neglected. This child was a victim of abuse by her mother. Being raised by a person who is in active addictions is a highly abusive environment to raise a child. I'm not saying mom didn't have her own needs, but leaving a child with an active addict is inappropriate. She witnessed drug overdoses. There were dangerous people. The mother engaged in survival sex work to fund her addiction and to repay her drug debts, and this child witnessed that. That's not acceptable. And I think when I come from a perspective of saying, Is it possible for us to look at this work more from a view of a whole child? How can we have a whole child approach? How can we consider her health? What was that child's early maternal care? What was her early childhood health? Well, actually, this young girl was identified very early with a serious genetic condition and a serious heart disorder. She had very significant medical needs, again, yet lived in the downtown east side, passed out in the parks, passed out on the SkyTrain, continually bouncing around without health care. Certainly not a model of health care. And I think there's a very significant role for health directors and First Nations health directors and First Nations Health Authority to help the province and help girls like Paige, because we need a very much intergenerational, trauma-informed approach to healthcare and to treatment around addictions that has a very strong family-centered model and that is strengths-based. And by strengths-based, I mean we can't point fingers and say, oh, well, her mom's an addict, what a terrible woman. Well, of course I'm not going to say that. We all come from, particularly those who are First Nations, know in our families we've dealt with the intergenerational impacts of addictions. There's a reason why people turn to addictions. There's a reason why this little girl's mom was an addict. She deserved support, but she could not be a primary caregiver when she was in that situation. But that doesn't mean we judge and discard people. We have a strengths-based approach to dealing with people. So when we look at the needs of some of our most vulnerable children in British Columbia, I have to say that frequently they are left on their own with a standard of care that is grotesquely inadequate. And even though I know and I celebrate the development of the First Nations Health Council, the First Nations Authority, and transferring the federal resources over to First Nations control to change the model, and I know it's going to take time, the footprint isn't different yet. There are so many opportunities to change it, but I really would urge and encourage you to do some learning, and if you can, I will make sure that report is shared specifically with you as directors, and you can bring your lens to it. And some of the tools that maybe you're using to work with families that have intergenerational trauma, and how we can boost resilience for young people, because we know there are young people in families with profound intergenerational trauma, and they are showing resilience and they are doing well. It isn't entirely a bad story about what's going on. It's just we continue to have what I call this pathway. And as I will tell in this report, that pathway, for instance, to Vancouver, urban, downtown east side, is a dangerous pathway. Ironically, this little girl lived in 50 SROs and was homeless, while at the same time, Wally Opal was conducting an inquiry just down the street into missing and murdered women. Like, why do we not connect the dots? I mean, these children have a right to be safe. The standard of life that they live is unacceptable. Yet also that child, her death at age 19, which we've investigated, went without any review in a health authority, in an education system, or in the Ministry for Children and Families. Nobody went and reviewed it and looked at it. It was that ordinary that it wasn't looked at. So learning from people's actual experience and disrupting that pathway. Disrupting it means intervening positively to stop violence, intervening positively to support a child, intervening positively to support a child's relationship with a mom who is in active addictions. Doesn't mean she's the primary caregiver, but to do that. How do we do that? And in the meantime, how do we make sure in the chaos that is part of families who are dealing with addictions that there is good primary health care? This is a little girl that didn't have a family doctor. She went in 3 times to the hospital for abortions or pregnancy terminations, and she had no reproductive health, because pregnancy termination and abortion is not reproductive health. when you're 16, 17, and 18. And as a result of the fact that she had no family doctor and was living on the street, she became acutely ill multiple times after those procedures because she developed serious skin infections. She had head lice, she had scabies. The list goes on and on. Every one of these areas are preventable health conditions that could be responded to, yet are happening to a young person here in our community in Vancouver. And I say this because these are the difficult discussions that we actually have to have when we talk about First Nations children, which is how are we going to work together to change those outcomes? And who is accountable? Who will step up to be accountable? Who will respond? And how will we do things differently? But if we choose not to look at the actual pathway that these children experience through education, health, the child serving system, we'll never learn. We have to learn and we have to do better for them. And of course we need resources and partnership, but the one thing we really need, which isn't about a program, it isn't about a government, it isn't about a program, it's that ability to really stay focused on a whole child and to do everything within your power in your life, whether it's in your job and health, or more widely in your role in your family, or your role in your community, to absolutely make sure those children have the best support that they can get, and to be safe, that they feel the right to be safe. They are heard. They have the right to grow and learn. They have the right to a healthcare system at least equal to the standards of health of all children in British Columbia. They also have that fundamental right, which is so protective for the resilience, to be connected to their language, their culture, and their community. Whether it's through their clan system or their house system, that there be substitutes there when their families fall apart to make them understand who they are and who they're connected to. That is so connected to resilience for these young people. And we frequently see that fork in the road where we can actually do that connecting. And so the work that you're doing, I would just say I really support that work. It's very challenging. There are very serious discussions that are required in British Columbia to make meaningful change for the actual children in the system. There's very serious discussions that are needed for previous generations who have been harmed in the child welfare system. But one thing we really can control is what will happen to this generation and future generations. That's our responsibility. And if anything, we want to have a very clear and unequivocal record that every effort was made by Aboriginal people in all of their places of leadership, serving in competencies and roles in health authorities, in FNASC, and delegated Aboriginal agencies. All efforts were made to keep those children's interests at the forefront. And when an opportunity presents itself for us to take that whole child approach, if we could get education, health, and child welfare together to really push for good outcomes and that whole child approach, I think that could be quite significant to improve that, to really build on that strength where we've seen huge capacity come to the fore. So I'm very, very much supporting that, and I think there are lots of opportunities looking at your experience in health, also looking at the experience in education. And I'm happy as representative to support that in any way as I can. I'm also happy as representative to support you around any cases that you have if you think advocacy services would be helpful from my office. I'm going to end by just introducing you to my two staff that are with me today, so you'll know who they are as well. Some of you probably already know them. Dawn Whiteman-Thomas, if she could stand up, please. Dawn is my deputy representative. And I'm not sure if Sean Daniels is in the room. She just stepped out, but Sean Daniels is also with me. And again, we are fundamentally an Aboriginal serving organization. Even though we're an independent office of the Legislative Assembly, we have a strong focus on serving Aboriginal children and being committed to supporting Aboriginal organizations and representing diversity of Aboriginal peoples in British Columbia in our staff. But there's a reason for that, because Aboriginal children are among the most vulnerable in this province, and they need not just oversight and advocacy, but they actually need better service, and they need to have an opportunity to have full and supported lives and good quality services, especially health services, that frequently can make that huge difference for them to grow and learn. So with that, I'd like to thank you and wish you all the best at your conference.